Ladies and gentlemen, now we present Dr. Ano Castro to give us, she is an oncologist and chairman of the board of Al Gaif Hospital and University Center since 2020. Mr. and Mrs. Castro will give us a talk. Will give a talk about the management of recurrent and metastatic head and neck squamous cell carcinoma. We call you to start your presentation, Dr. Castro.
Hello, good afternoon to everyone. And just sharing my screen. Hopefully you can see it. So it is a pleasure to be here with you in this conference, even if it's in this format virtual thing, but hopefully the next year we can have all together. So the aim of my talk is talk about management of this recurrent and metastatic disease. And we have the guidelines. They were presented and approved by the ESMO that put the patients into the previous treatment they have. I think we have we can have this approach, or we can have another approach, a little bit different, that it's more easy to think about it. So I split these treatments in two different diseases. So if you need a response, so if it's a very quick disease, very quick progression in a localization that you need very quick response because the airway is compromised, or if the patient cannot swallow, you have one kind of disease. Or if you have a stable disease with a unique lesion, perhaps in lung, then you have a different disease and you can have different choices. So first, we are looking at the need of response. So any or unknown CPS. If you have the chance, always collect samples to make the determination of CPS score. But in this case, the patients, they will need chemotherapy with Erbitux or with pembrolizumab, but they will need for sure chemotherapy for a quick response. Then if you think about your patient and you are trying to sequencing treatments, the point is that in the second line, you have after Erbitux plus chemotherapy, you have immune checkpoint inhibitors in monotherapy that is approved, and you know the results. And after pembrolizumab plus chemotherapy, you can have Erbitux plus chemo, maybe, or you can have monotherapy, but you don't have, still don't have these data for the sequencing treatment. And as you can see here, the regimen that was approved, Extreme, it was approved for many years ago and was our standard of care. If you look here and regarding the progressive disease, you have independent of the CPS score, you can see that they have a better response regarding progressive disease. So with immunotherapy, it seems like you need a little bit more time to have the results. And when you have the results, the results are pretty consistent. But if you need a response, maybe you have to think about desequencing, okay? And then if you look in the data for sequencing treatments, so you have first line with Extreme or TPEX, for instance, the other trial that was presented, you see that median overall survival with each regimen followed by immune checkpoint inhibitors, you can see that you have 9.4 months in median overall survival or 21.9 months. So this is really good. These are very good results for this kind of population. So we are talking about recurrent metastatic. So we are not talking about patients who can be cured, okay? Then if you look in the stable disease, so you can split in different arms. If you have CPS more or equal to 20, you can have pembrolizumab in monotherapy, then you have sequencing treatment. Why monotherapy? Because if you compare pembrolizumab in monotherapy or pembro plus chemo, you don't have a big advantage, and you have, of course, the toxicity of adding a lot of treatments together. You are not curing the patients, so you have to regard the quality of life of the patients. Doesn't matter if the patient lives longer, if the patient does not, will live better. So if you can see the PFS on the right side of the screen, the only thing that you have to keep in your mind is that you need to follow up the patients very close, because if you see the main progressive disease, it will appear on the first 4 to 5 months. So if you have pembrolizumab in monotherapy for your patients, you must look for your patients very, very close, so you can see the progression and change your attitude in time that the patient can have the benefit. And if you see in the second line after pembrolizumab monotherapy, you can see if you use Erbitux plus chemo, you still have efficacy after this first line. So you can see that you still have 53% of your patients that have an overall response rate post immune checkpoint inhibitors regimen, as you can see. So this could be a very good option for those kind of patients. Then if you have CPS less than 1, for that patients, immune checkpoint inhibitors are not approved in the first line, but you have the results here. There is no great benefit. And then if you look to the other part of the stable diseases, from 1 to 20, then you have both regimens that you can choose, and how can we choose and why do we choose? So you can have this in mind. So you have median overall survival, you have PFS, overall response rate. It depends on what you need most for your patient. If the response is the thing that you need the most, independent of the CPS, you can see that you always have the same response with the Erbitux plus chemo. The other options, so pembro plus chemo, you see that the benefit will grow when you have increasing CPS. As the same in PFS and the same in median overall survival. So I think you have to be very careful when you choose the treatment to your patient. The other thing that you have to be, that you should remind, is that not all countries have these regimens approved. So it doesn't matter if you say that pembrolizumab plus chemo should be used if you don't have the allowance from the government to use it for your patients, or if the patients cannot afford. So this helps you to decide and see that even if you treat your patients with this regimen already approved for a long time, you will not lose your patients, and it will not be harmful for your patients, okay? And then if you can see in overall response rate, as we talked before, if you compare extreme and pembro monotherapy, of course, extreme is much better. That's why in these specific patients, you will not use pembro alone. And if you look in the pembro plus chemo versus extreme, you can see that the results for median overall survival are better with the pembro plus chemo. But if you compare PFS or overall response rate, it's still better for extreme. The other thing is that if you look to the subsequent anti-cancer therapy that the patients received, you see that 53% of the patients that receive extreme in first line were able to receive a second line. And only 41% of the patients that received the first line with pembro plus chemo had the opportunity to have a second line. This is, of course, because the patients are exposed to a very toxic combination, either with extreme or with pembro plus chemo, and the patients are very frail. So it's obviously the second line is not able to have patients. As you can see, the second line with the nivolumab that is approved, after chemotherapy with Erbitux plus chemo, you still have 7.1 months from median overall survival. That it's really good, and it's pretty consistent if you look in the real world studies that you have around 10 months of median overall survival. And the other thing is that when you look into the data that was published, you have PFS2 on the Keynote 048 that is reported, but I think the PFS is not the best surrogate endpoint, because if it was not in the first part of the study, I think in the second one is not the best one. But you have this data that was published, but I think we still have a lot of questions regarding those sequencing treatments. These are the main issue. But you can see that if you look to the data, you have a very long median overall survival for our patients in the second line, when we were talking some years ago that you don't have alternatives for those patients. So it's a very good advance in clinical trials and in clinical evidence. If you can see the overall survival at 12 and 24 months on patients who have a second line after the first line, you can see that you have in the second line chemotherapy-based therapy, you have 67% of the patients that are alive and 27 at 24 months. And if you use second line with immune checkpoint inhibitors, this number increases, and you have 78% of the patients alive at 12 months and 37 at 24. So I think you don't lose if you are not able to use pembrolizumab plus chemo and you have to use chemo plus Erbitux. You will not lose patients. You can see that your patients still have a good survival. So finishing and considering the most appropriate treatment sequence for each patient, I think it's crucial. First, the treatment decision should be based on patient needs, patient characteristics, and disease characteristics, and should be always decided in a multidisciplinary team, okay? And you need to check if the patient needs response or not, and if this response is important. So patients should have the opportunity to receive both Erbitux and immune checkpoint inhibitors in their treatment journey, so they can have the best treatment they could. The efficacy of pembro plus chemo is greater in patients with higher CPS. So that's why it's very important assessing CPS when the patients have a recurrence or a metastatic disease. The high response rates and low disease progression associated with chemo plus Erbitux allows the patients to receive more than one line of therapy and could extend overall survival. And the use of immune checkpoint inhibitors therapy in second line did not negatively impact the outcomes. So I think if we don't have all the opportunities to do it in a first line, if you use it in a second line, your patients still benefit from this sequencing treatment and have the best of all treatments. This was I brought to you. Hopefully it was clear enough. Thank you.
Thank you, Dr. And questions after session? We now open the theater for any question from the ground.
I have a question for. Thank you very much for your elegant presentation. I am confusing when using the pembrolizumab and all immunotherapy. Sometimes you use the term combined positive score CPS, and sometimes you use tumor proportion score. And I think it's very difficult for me to memorize which is more than or less than 1, more than or less than 5 or 20. So I think for pembro they used more the combined positive score more than tumor proportion score. So what is your opinion about that?
Yeah, it's a good question. So when Pembro was approved in the second line, the score that we used was TPS. And then we have those results from the 048 that only talks about CPS. And I think if we think about immune checkpoint inhibitors, if you want to use it in a first line, I think I use always CPS because it's most reliable score that you have, and you can use it either to decide monotherapy with Pembro if the patient has CPS more or equal to 20, and it helps you deciding if you combine with chemo if it's between 1 and 20. So I think I would stick only for CPS, even though CPS score is not so easy to make the determination. So the pathologists have to be very trained about this score because it's not simple. It's not a simple way to determine this score. But I think this is the marker that we look nowadays for deciding for pembrolizumab.
Okay, thank you.
Okay, thank you. Can I ask about the terminology of hyperprogression by the immunotherapy, which is a French head and neck group noticed a group of patients that develop a hyperprogression during receiving pembrolizumab or a checkpoint inhibitor. It maybe give the reason to why the pembro monotherapy was inferior in the overall response rate and the BFS, and despite it improving the overall survival. And if there is another biomarkers to predict which patient will have a hyperprogression or not.
This is something that we are all looking for because we would like to select the patients previously and not submit the patients to a treatment that will grow even faster the tumor. But I think, unfortunately, we don't have still these markers. I think it's the aim for the next clinical trials to look this. But although we have some cases of hyperprogression, this is not so much as you can see in melanoma, for instance, and that's why I think more than the CPS score, if you have a recurrence that is in an airway or in a localization that will compromise the life of the patient, you should be very careful using immunotherapy, and you should monitorize very closely because at the minimum sign that you have a progression, you should change immediately the treatment. So don't wait that it will become worse and then become better, because this could take the life of your patient. And you cannot afford to wait as melanoma patients, that you can wait for maybe it will become better. If it's a recurrence in a larynx, for instance, in the neck, the patient will not stand this progression. So I think more than hyperprogression, you have to be very careful about only the progression and keep your patient very close. Regarding the markers, I think everyone wants to try to see which patient could fit better for starting the treatment with the right treatment, because this could be the key for the better results. But I think we are still a little bit far from that reality, unfortunately.
Thank you.
Thank you, Dr. Anu, and for your fruitful talk. And now we move to
Now we move to the second lecture presented by Professor Vincent Gregory about target volume selection and delineation for head and neck tumors.
Thank you very much, Mr. Chairman, for your nice introduction. Thank you for inviting me to participate to this lecture. As said by the previous speaker, I would have preferred to be with you in Cairo or, or somewhere in Egypt, but this will be for next time. So what about target volume selection and delineation in head and neck tumors? Is this an issue? And I guess it's still an issue. If you look at these small tumors, T2 and 1, and if you ask radiation oncologists, well-known radiation oncologists, to delineate target volume, you see that they all delineate something different, excuse me. And this is a more recent, aspect or study which was performed 4 years ago in Denmark. You see that some of the coefficient of variation for target volume delineation reach 105%, meaning that there was absolutely no agreement between radiation oncologists. And even more, you may say, yeah, there are disagreements, but it doesn't really matter. I'm sorry, it does matter. If you look at this study, which was published a few years ago about combining concomitant chemoradiation with an hypoxic cell sensitizer, tirapazamine, it was shown that patients in red on this overall survival curve were patients that, in fact, were absolutely non-compliant with regards to target volume delineation and or target volume irradiation compared to the yellow patients or the patients in the yellow curve. They were fully compliant in terms of selection and in terms of delineation of the target volume. So yes, selection, proper selection and proper delineation of target volumes in head and neck do have implication. And when I mention the words, when I use the words implication, as you can see from this figure, it's a 20% difference overall survival between the compliant and the non-compliant patient. So how can we envisage the issue of target volume in the field of head and neck? And let's start with the primary target volume. We know the anatomy of head and neck, which is a complex anatomy. We know, for example, on the right, that if you have a supraglottic larynx, tumor cells can easily transgress the epiglottic cartilage to end up into the pre-epiglottic space. So it means every time we have a supraglottic cancer, we should include the pre-epiglottic space as part of the target. We also know that for tumors which are more than T1 of the tonsil, tumors can transgress the constrictor muscles and end up and disseminate into the parapharyngeal space. But the definition of the parapharyngeal space, as you know, is from the base of skull down to the hyoid bone. So it's 12 cm length. Do we always have to irradiate the full parapharyngeal space when we only have to deal with a small T2 or even a T3 tonsil fossé tumors? So yes, anatomy is obviously something that we need to take into account because we have barriers, we have routes for dissemination, but we need probably to be slightly more and put another parameter into the equation. This is, for example, a publication from 15 or 12 years ago from French colleagues where they irradiated a lot based on the knowledge of compartmentalization of tumors in the field of head and neck. And as you can see on these figures, they ended up with quite large tumor volumes. More recently, some years ago, 4 years ago, the Danish came with a different concept, the concept of geometrical margins. They say we can delineate the GTV in red for the primary tumor or for the lymph nodes, and then we put some margins that we will edit based on a little knowledge of anatomy. Cells will not fly in the pharyngeal space. in the airway of the pharynx. Cells will be confined within barriers, and the bone can be a good barrier. So they proposed a concept where basically you expand your gross tumor volume by 5 or 10 centimeters using simple anatomic barriers, air cavities, or bony structure, typically here, the cortex of the mandible. But is this something which is based on data? Yes. If you look on this graph, which is coming from a small series of patients, 10 patients with partial glossectomy, and this American group, they looked at the infiltration, the probability, the probability of infiltration on the y-axis as a function of the distance from the main front of tumors in the x-axis. And you see that the probability of having microscopic cells infiltrations is typically within 5 millimeters, which means that indeed a finite barrier could be used. There is another more recent study which was also proposed. They looked at various imaging modalities. They compared the various imaging modalities with the tumor specimen, here a total laryngectomy for locally advanced laryngeal or hypopharyngeal tumors. And they typically observed that from the margin of the GTV, microscopic tumor infiltration was within 4 to 6 millimeters. So yes, indeed, there is a finite progression of the microscopic tumor cells from the limit of the gross tumor volume. And when you look at surgical literature, you can find quite a few publications, or maybe more than a few, quite a lot of publications when they do endoscopic surgery for typically T1 or small T2s. They typically use a rather small margin of 2 to 5 millimeters. And for these patients, they don't always go for post-op. Hopefully, they don't always go for post-op radiation. And they can report, or they do report, local control of 95% without any post-op radiation, meaning that a small margin of 2 to 5 in selected patients' population, I agree with you, was quite adequate. And when the Danish changed their policy and they said, no, we are now going to set up a guidelines committee and we are going to set up guidelines, which was to use 5 millimeter and an additional 5 millimeter around the GTV. As you can see from the right column in green, the coefficient of variation between centers or between radiation oncologists dropped from 100% to 40 or even less percent. So obviously you can indeed go and try to homogenize your practice. So we were left with two schools. The anatomic margin schools, you only delineate your clinical target volumes based on compartmentalization of the head and neck anatomy, but it can be quite large. Or you only do geometric margins, which was proposed by the Danish, 5 millimeter for a large dose and another 5 millimeters for a slightly lower dose. But maybe the two could be combined. You use the geometric margins, but you edit your margins based on the deep knowledge of the complex head and neck anatomy. So in other words, what we based the proposal is from the margin or the border of the GTV, you have a decreased probability of microscopic tumor infiltration. You take the first 5 millimeter to deliver high dose and the second 5 millimeter to deliver a more prophylactic dose, but everything is quoted, unquoted, edited based on the knowledge of anatomy. What do I mean? This is a fake GTV in red. It's a 1 cm margin in blue, which goes into the air cavities and includes the epiglottis, Do you believe that cells will fly from the base of tongue to the epiglottis? Obviously no. So you edit to remove the air cavities and to remove the epiglottis. You are left with the green CTV, and then you can define a smaller CTV that will receive a much higher dose. So you do the geometric margin, but you edit for anatomy, for air cavities, for barriers, which can be fascia, which can be cortex of bone, and you experience and expertise of other colleagues, meaning the head and neck surgeons, to delineate your target volume. To do that, you need to acquire very thin section, 2 millimeter thick sections with IV contrast. I repeat, with IV contrast. You use the clinical examination, including the fiber optic examination that we as radiation oncologists should always do. We take into account the endoscopic examinations. We don't do it, but we may have drawings or pictures given to us by head and neck surgeons. And then we also use CT, MRI, or maybe FDG PET from the diagnostic imaging world. We combine this information to be able to draw the GTV and then the CTV low dose and the CTV high dose. Let me show you a few examples. You see on the left a glottic squamous cell carcinoma including the anterior commissure going into the ventricle, as you can see. It's a tumor including going into the ventricle. It's a T2. You see the tumors on this coronal view and this axial view. We did take a margin of 1 cm in blue. For T2 supraglottic, of course, you do not include the strap muscle. Of course, you do not include the skin above the larynx. So we did an editing based on knowledge of anatomy. We did not include the air cavities. We did not include the contralateral arytenoid. We end up with the green CTV that will receive a prophylactic dose. And then within the green CTV, the yellow CTV, which is GTV plus 5 millimeter, will receive a much higher dose. This is another example of a big T4 glottic squamous cell carcinoma. As you can see, a T4 glottic, for me, the best treatment is a total laryngectomy. No discussion. But this particular patient refused. Then I did delineate in red the GTV, an expansion of 1 centimeter in blue. I did correct for few anatomical barriers. Mainly, I did correct for the air cavities. And I end up with the green CTV that receive a prophylactic dose. And then within this green CTV, in yellow, the CTV that will receive a very high dose. It's another example of a T3 supraglottic. You can see with a fixation of the larynx for those patients who are not treated by preservation with induction chemo. You can go for concomitant chemoradiation. You have the GTV in red. You have the 1 cm expansion in blue, which goes even into the vertebral body, including the hypopharyngeal and the retrocricoid space, which obviously need to be edited. This is what we did in green. This volume received the prophylactic dose, a smaller volume in yellow did receive a high dose of typically 70 gray. Another example of a T2, exophytic T2 of the piriform sinus. You can see very well the tumors on this IV contrast CT. This is on the IV contrast planning CT with the GTV in red, a 1 cm expansion in blue, corrected for anatomy. We excluded the vertebral body. We excluded the longus colli and the longus capiti muscles. We excluded the vessels, the hyoid bone. We end up with the green CTV. and then within this green CTV, a higher dose will be delivered to the yellow CTV that you see on the slides. I moved on quite quickly. This is a posterior hypopharyngeal wall tumors. It goes up, up to the vertebral body. It was decided not to go for an operation which was not possible because the pre-vertebral space was invaded. We decided to go for concomitant, for concomitant chemoradiation. We did delineate in red the GTV based on all the information, an expansion of 1 cm corrected for the anatomy. We removed the skin, we removed the air cavities, we removed the left hemilarynx. This was the green CTV, and within the green CTV, a 5 millimeter margin around the GTV, and we got the high dose CTV. It's a small T2 tonsil fossé squamous cell carcinoma. You can see it quite well on the endoscopy or fiber optic examination and on the MR. It has been delineated in red with an expansion of 1 cm, excluding the pterygoid muscles, excluding the air cavities. We ended with the green CTV for prophylactic dose, and then with a 5 millimeter expansion of the GTV, we reach the therapeutic dose, the high dose CTV, typically of 70 gray. I'm close to the end with this huge T3 tonsil, from one tonsil fossé to another one invading the soft palate. We did report on this axial CT, and you have the coronal CT on the right, the GTV, a 1 cm margin in blue, corrected for the anatomy, corrected for the air cavities, corrected for the vertebra, corrected for the longus colli, longus capiti muscles, pterygoid muscles, and then we end up with the green CTV, prophylactic CTV, and then within the prophylactic CTV, the therapeutic CTV in orange, in yellow, A similar example with a T3 oropharyngeal. I guess now you must be familiar with the philosophy. This is again a last example with a posterior oropharyngeal wall tumors. You see in red the GTV, an expansion corrected for the anatomy. We have the green CTV, and within this green CTV that received a prophylactic dose, we could then delineate the yellow CTV that received a high dose of, let's say, 70 gray. All of this has been recently, I mean, almost 3 years ago, published with a bunch of experts in the field from different places in the world. You may say, yeah, but is it that important to be so careful in doing the target volume delineation? You see a T2 M0 laryngeal squamous cell carcinoma. You see the endoscopic picture on the upper left. You see on the top row, you see the French guidelines on the left. In the middle, you see the Danish guidelines, and on the right, you see the international guidelines. You have the numbers in terms of volume written below the images. You see that if you use the French guidelines for a similar T2 and M0, you will end up with a much larger CTV than what we propose within the international guidelines, and also what has been proposed within the ANCA. This is another example. It's a base of tongue tumors with ipsilateral lymph nodes, and you see that these guidelines makes a big difference in terms of target volumes, with a volume which is half with the international guidelines, half the volume proposed by the French guidelines. And if it's not useful to increase by a factor of 2, the CTV will mean that you will end up with much with much more toxicities, and you know toxicities over there. It's not only the swallowing function, it's also the swallowing. It's not only, excuse me, the xerostomia, it's also the swallowing function, and to spare the constrictor muscles is obviously something that will do very good for patients. Limitation before closing, you may say, yeah, but all of this has been done on few patients, on few samples. What is the sensitivity? There are some methodological issues because you collected samples, maybe there was some retraction, the issue between the pathology and the CT/OMR, there were issues of image registration. We never do a cell qualification. In other words, where the cells, the stem cells, where the cells, the hypoxic cells, we may need to refine the dose prescription based on these factors. And you may say, yeah, but during treatment, things will change. So we may want to go for adaptation. All of this is absolutely true. However, this is a publication from the Danes where they looked at local control at the T site, at the primary site. And you see that indeed there is a difference between in plain line centers that did not use any margin around the GTV, and the one in dotted line or in gray line, faint line that use either 4 or 10 millimeter margin. So obviously it will impact the margin that you are using, and a no margin is obviously not enough. Whether a 5 or 10 millimeter margin seems to be similar. And more recently, they compare the pre-guidelines local control to the post-guidelines local control, the post-guidelines being much more uniform, as I mentioned to you. And as you can see from this picture, there is no difference in terms of local regional failure looking at the pre-guidelines time 2010 in blue or the post-guidelines times 2014 in red. Obviously, there is clearly showing that the use of guidelines has plenty of benefit without negative value in terms of recurrences. Pay attention, and this is my last slide. We always need to have a PTV. What I proposed is not for post-op radiation. We need other guidelines that are being developed. It's valid for P16 negative and P16 positive, but it's only valid for squamous cell carcinoma. If you have an adenoid kystic carcinoma, don't use these guidelines. It's only valid for oral cavity, oropharyngeal, hypopharyngeal, and larynx, not for nasopharyngeal. There are other guidelines published in the same issue of the Green Journal. If you have a recurrent tumors, don't use these guidelines. If you are several radiation oncologists working together, please peer review yourself. You will learn a lot and you will improve in terms of quality. If for whatever reason you are missing some piece of information, you cannot do a proper clinical examination, which is of paramount importance. You do not have a good CT or a good MR, don't do it. But the price will be that you will probably have a much larger target volumes and then much more complication than with an optimal target volume, and also try to combine or to regroup these patients together, because in experts' hands, this will give much better results than if you are not used to do that. With that, I would like to thank you very much for your kind attention, and I'm open for questions should you have questions.
Any questions, please? Yes, go ahead.
Okay, thank you, Professor, for your lecture. I just want to ask about does these guidelines of using 5+5 millimeter margins, does it account for the submucosal spread that can be sometimes seen in some tumors?
That's a very good question. That's why you need to have a clinical examination, because the only possibility for you to view the submucosal or the mucosal spread is by a proper clinical examination. And then indeed, your GTV will be maybe adapted, maybe slightly larger than what you can see on CT or MR, because you have taken the submucosal or the mucosal infiltration, and this will be the border of your GTV that you will expand by 5 and 10 millimeters. So that's why I insist you cannot properly delineate target volumes in the field of head and neck without a proper clinical examination. It might be different in other disease, but I'm not an expert in other disease, but in head and neck, the clinical examination is paramount.
Okay, thank you very much.
Any other question?
Thank you for this nice presentation. I would like to talk about usually treat when we delineate for any definitive radiotherapy for a case like for larynx or for base of tongue, we used to treat in three volumes or 2 volumes. The first one including the whole lymph node involved, and then we boost to the tumor volume with margin. So you change everything and you just irradiate only the gross tumor you can see on the CT only. This is true? I understand this well or not?
No, I'm sorry if I confused you. I decided to only report on the gross tumor volume on the gross tumor target volumes. So on top of what I've discussed this afternoon or this evening with you, you need indeed to consider the prophylactic or the therapeutic lymph node irradiation. But this is a topic which I decided not to address because of the sake of time this evening. So I only discussed the primary tumor target volume delineation and not the nodal target volume delineation, which obviously you need to do.
So you basically are talking about the phase 2 or the boost part of radiation, not the whole volume.
So I was only talking about the way you should manage the primary tumor target volume with 2 volumes, GTV plus 10, a prophylactic dose, GTV plus 5 millimeters, a curative dose of irradiation. And on top of it, you delineate the target volumes for the nodes, either on one side of the neck or on both sides of the neck.
Okay, thank you very much.
That was an important question. Thank you for asking, and I'm sorry for the confusion.
Thank you very much for your outstanding presentation. I have a question and a comment for you, Professor. First of all, I have to tell you that I'm not a clinical oncologist. I'm an otolaryngologist and a neck surgeon. The first question to you, would you prefer to discuss the delineation with the surgeon who has made the endoscopy and examined the patient? And the comment is that if there is any failure after IMRT, which is a great achievement in radiotherapy, I think we as surgeons go for surgery while we are not at a great pressure, because actually the tissue dissection is much easier than the radiotherapy, the usual radiotherapy. IMRT patients, when they undergo failure and we go for salvage surgery, actual surgery is much easier and complications are less. This is my comment and this is my question for you.
So let me first answer the comment. I'm very pleased to hear about your experience, because indeed the use of IMRT should have translated into less normal tissue irradiation. And I'm pleased to hear that when you have to do salvage surgery, it's easier for you in case of IMRT compared to the old time or the old radiation technique, if I understood you well. Thank you. The first question, I definitely agree with you. I always discuss the clinical target volume delineation with the head and neck surgeons, because you are the one who did the endoscopic examination. You are the one who put your finger to palpate the base of tongue. You are the one writing, taking pictures, or sometimes taking a movie. And we, as radiation oncologists, we definitely need to know this information. We also need, as radiation oncologists, to perform the fiber optic examination to be able to see the tumor extension, but we need to discuss with you. That's what I always do with head and neck surgeons I'm fortunate to work with.
Thank you so much.
Another question, please. As you know, in lung cancer, now they exclude the elective nodal irradiation from the treatment of radiation treatment of lung cancer. Do you think it is also suitable to use the same idea, excluding elective nodal irradiation in head and neck cancer? And if the patient develop nodal recurrence, at that time we can do excision and then followed by radiotherapy. This will decrease the toxicity of and morbidity of radiotherapy. So what do you think about that?
That's a good question. As you know, and I guess your colleague head and neck surgeons know it probably better than I do, we typically, when they perform a prophylactic neck node dissection, a selective neck node dissection, there is about 20-25% of microscopic infiltration, at least in the most important nodal area. So whether you believe it's not high enough to do a prophylactic treatment, I would believe that 20-25%, it's obviously high enough not to dis-treat or to not to treat, so double negation, the neck. What we do, and in the future we'll do even more, we are very selective in the levels we need to irradiate. We don't irradiate always on both sides of the neck. We not always irradiate every lymph nodes. We know for node negative oropharyngeal, we need to go for level 2, 3, and 4. And if it's a very lateralized tumors, we may even not have to go on the contralateral side. So we can make a really a la carte selection, considering the levels and considering the laterality of what we have to do. Should we decide not to do it and wait until we have a recurrence, the experience in the field of head and neck is that the salvage surgery of the neck is typically not always effective. And then you end up with a patient that you could not treat because the node has developed too immensely. It is infiltrating the paraspinal muscles. It's becoming non-resectable, and there is no way with irradiation, even with concomitant chemoradiation, that you could try to rescue this neck. So today, there is still indications to do prophylactic irradiation, but only on selected levels and only on one side of the neck for some clear indication. And I'm strongly believing that in the future, things will also evolve to be even more restrictive, but still we will stick and still irradiate few parts or treat, whether it's surgery or radiation, some neck node levels.
Any more questions?
Hello, Dr. Vincent. Would you consider omitting selective nodal irradiation in a node-negative post-op head and neck cancer?
You mean it's post-operative? All the nodes have been removed and are negative, so it's a P and NORD. You're asking me whether I would not irradiate the neck. The answer is yes, with two conditions. Number one, I need to know who was the surgeon, whether it was knowledgeable or not. That's extremely important. And I do apologize. I don't want to offend any surgeons in the audience, but it's extremely important. And there are guidelines. The surgeons knows what they have to do. The pathologist knows how many lymph nodes they have to analyze. And number two is that indeed, we need to be sure that enough lymph nodes were analyzed. If it's a neck node dissection with 3 lymph nodes, there is something wrong. If it's a lymph node dissection with 15, I think the criteria is 15 or 18. I'm sorry, I'm always forgetting whether it's 15 or 18. For selective neck node dissection, P and NORD, I do not post-operatively irradiate the neck. That's my answer to your very good question.
Even in oral cavity cancers, not just larynx and oropharynx?
I do it for every diseases, at least oral cavity, oropharyngeal, hypopharyngeal, and laryngeal. But sometimes you may say a neck node dissection was performed, but they did not, for obvious reason, they did not dissect the retropharyngeal lymph nodes. They typically do not do it. If it's a posterior pharyngeal wall tumors, you may decide as a radiation oncologist to say, I need to deliver a prophylactic dose to the retropharyngeal lymph nodes because they were not dissected. But that's slightly a different question. But I gave, I guess, a clear answer to your question. Thank you.
Thank you.
Another question related to this question also. As you know, some surgeons, for example, in case of cancer larynx, prefer not to do neck dissection at all. They just do total laryngectomy, for example, without doing neck dissection. And when you ask why, he said it can be, lymph node can be eradicated by post-operative radiotherapy. Did you prefer something like that? Which is better, to do only surgery to the primary tumor if there is no palpable neck lymph node, leaving the neck lymph node for the radiation, or it is better to do from the start total laryngectomy and lymph node dissection?
I favor total laryngectomy and neck node dissection. We will have a good staging, and if it's P and NORD on both sides, I may decide to only restrict the post-op irradiation on the primary, meaning I will avoid irradiating the lateral sides of both sides of the neck. You may say, yeah, but what's the point? Because the volume will not be that different, which is true, but at least you will have a proper staging of the neck. And I favor either you go for full operation, T plus N, and then you adapt your irradiation based on the pathologic analysis of the specimen, or you decide to go for a full concomitant chemoradiation or full radiation treatment alone, and you reserve surgery for salvage. But having said that, for T4, I fully agree with you that surgery is the way to go, no discussion.
Okay, thank you very much, and we actually appreciate your presence with us in this presentation, and hope we can meet you in Egypt soon, inshallah. Thank you.
I would like to be in Egypt with you. It would have been much better for me, and I guess for you. Thank you very much again for your kind invitation. Have a good evening.